Today I'll be talking about the Motor Assessment Scale, or also known as the MASS. So what is the MASS? The purpose is to assess everyday motor function in stroke patients. In the area it assesses are activities of daily living and functional mobility, and the MASS is developed by Carr et al. In 1985, and it was recently revised in 2014 by Sabari et al., and I'll get into why it was revised a little later on in the presentation. So a little bit about the MASS. The age range is 18 to 65 plus years. The administration time is 15 to 60 minutes, dependent on the level of function of the individual and how long they take to complete the tasks. The assessment type is observation, and the population is commonly used with individuals who sustain a stroke. However, if the individual requires a proxy to aid in the completion, or if the individual has aphasia, then the MASS should not be administered. And the MASS can be administered in both an inpatient and an outpatient setting. So these are the 8 items that the MASS assesses, and it also assesses 8 different areas of motor function. So the first area is supine to side lying, supine to sitting, then balance sitting, sitting to standing, walking, upper arm function, hand movements, and advanced hand activities. And then items 6 through 8, so that's the upper arm function, hand movements, and advanced hand activities. These can be assessed independently from the rest of the scale in order to gain a better understanding of solely the individual's upper extremity functions. Then this is a list of all the materials that are used within the MASS. However, not all of the items will be used for each individual. So some of the items listed are essentially used as downgrades if the client cannot complete the highest level of the task, which I'll get into in a few. So some considerations when administering the MASS. It is assessing the functioning of the affected arm and or leg. The patient will perform the task 3 times, but only their best performance will be recorded. And if the patient is able to complete the higher level item, then the lower level item can be skipped. And this is because it's assumed that if they can accomplish the higher level task, then the lower level items are easily achievable. So it's like a hierarchy. The patient's general tonus is observed throughout the assessment. And so general tonus is the presentation of tone within the patient's arm, which is further defined as hypertonus, hypotonus, or consistently normal. And it's stated on the instructions or scoring sheet that the test is intended to look at the patient's ability to move with low tone or in a synergistic pattern, and finally move actively out of that pattern into normal movements. So this is why it's critical that the general tonus is observed throughout the administration of this assessment. And then the order of the administration of items 1 through 8 can vary to accommodate the patient's needs. So these are a breakdown of the items and how the clinicians are able to assess the individual's ability to complete the tasks. So as you can see, the tasks are listed. The task that's listed number 1 is where the patient is requiring the most help or assistance. And then moving to task number 6 is where the patient is the most independent. Something else to keep in mind with this is that if the patient is unable to complete any part of the item, then they receive a score of 0. Then this is just another breakdown of the items. So this is items 3 and 4. Then again, this is the breakdown of items 5 through 6. Again, following that same hierarchy of number 1 being requiring the most assistance and number 6 being the most independent. Then these are items 7 through 8, again following that hierarchy pattern of 1 being the most assistance required and 6 being the most independent. Then this is a breakdown of the general tonus of in how you are supposed to be observing it throughout the administration of the assessment. So there are 2 variations in how this is scored. So this is honestly a highly criticized area of the MASS due to the subjectivity, the lack of guidelines, and the unreliability of this overall measure of it. This is because it doesn't specify how to differentiate between the tone in, say, an individual's arm versus their leg versus their trunk. So this is just a highly criticized area of the MASS. For scoring, this is where the scoring sheet on the left is the original, and this is based on the 7-point scale. So you'll mark based off of the administration sheets that were presented above. You'll mark down in the scoring sheet if what number they scored. The scoring sheet on the right is the revised scoring sheet. So this takes into consideration the lack of validity the hierarchy of tasks are within both the hand movements and the hand activity items. And so this means that an individual's ability to complete the highest level task does not automatically mean that they can complete the lower level tasks, and thus requires them to complete all the tasks that are listed. And so the scoring listed is based on a prorated value to provide an appropriate increment for the achievement of increasingly more demanding behaviors on the 10-level hand movement item and then the 8-level hand activities item. Then to interpret the mass, it's scored on a 7-point scale. So listed like as I presented above, you'll either score them as 0 or like 0 through 6. And then a score of 6 indicates the optimal motor behavior. And a score of 0 would suggest total dependence, whereas a 6 suggests independence and or modified independence. And then all scores, with the exception of the general tonus, are summed to provide an overall score out of 48. And on the instructions or score sheet, it states that the higher the score, the higher the functioning of the patient is on their affected side. Then this is the normative data for mixed stroke. So this data was collected from a study that researched 61 patients with a mean age of 65 who are either in the acute or chronic stage of a stroke. So that's why it is for a mixed stroke population. Then this is the video for the administration, and this video displays the examples of the highest level task within each of the 8 items within the assessment, with the exception of general tonus, since that is observed throughout the assessment and honestly can't really be demonstrated. Then these are the psychometric properties. So it was found to have excellent test-retest reliability. And in a study that researched the use of the mass on individuals with a chronic stroke, it was found to have the excellent test-retest reliability. The excellent inter-rater reliability was established during a study that examined individuals in both the acute and chronic stages of their stroke through the use of multiple physical therapists administering the mass. However, within this study, the general tonus item was excluded. And then when compared to the Fugel-Meyer assessment, 2 separate studies found that there was an excellent concurrent validity. With the MDC, or the minimally detectable change, the score of 1.22, this means that an individual's increase in test scores must reach a 2 in order to be considered a true change. And overall, the mass is an easy to administer assessment that is beneficial when evaluating an individual who sustained a stroke's ability to complete functional tasks related to daily activities. And the 8 items of the mass also provide a holistic approach compared to other stroke motor assessments that only evaluate a few areas of motor function. And then these are my references. Thank you.